introduce Dr. NIDHI Gadkar, who is a cornea, cataract and refractive consultant at in Kashyap Memorial Eye Hospital. She'll be talking about penetrating keratoplasty with the title PK, but not just PK. Over to you, Dr. NIDHI.
Thank you, Dr. Nikunj, for making me a part of this wonderful IC. A lot of us young surgeons are trying to get out of our shell and do challenging cases. And this is just a presentation of few of them. I have no financial interests. So I'll be talking about PK and more. Now, a normal penetrating keratoplasty may include just removal of the host cornea button and putting a new, can you dim the lights please? And putting up a new donor tissue and doing the suturing. But sometimes, in spite of adequate preoperative investigations, there are a lot of surprises that may lie beneath the cornea. So in a routine OT, I usually keep the following at hand: a standard power PMMA IOL or a multi-piece IOL, 9O or 10O Prolene sutures with straight and curved ends, vitrectomy with trocar and cannulas, and intravitreal antibiotics. So this is a case of a 30-year-old male who deferred therapeutic PK advice by me for 7 months and then presented back with a large anterior staphyloma. This staphyloma was hindering the closure of lids, was cosmetically very disturbing to the patient, and if you can see, it was quite bulging out. So I planned a tectonic graft. The staphyloma was too big, so trephination was not possible. So first I deflated the staphyloma, and then trephination was easily done. Here a 13.5 mm trephination was done. The cornea was then cut into quadrants. Inferiorly, the iris was totally plastered to the cornea. Superiorly, the rest of the iris was sanuculized and careful dissection done not to cause further trauma to the iris. Lens was subluxated for more than 180 degrees. Did an anterior vitrectomy inferiorly and tried to dislocate the lens. But superior zonules were pretty much intact. So started a capsulotomy and then eventually removed the nucleus with the bag. Now there was a lot of bleeding and blood clots which were not going with washing. So I used a vitrector and removed all the blood clots. Found iris at the healthiest point and planned to do a iris repair to avoid PAS and further increase of IOP. Did it at 2 places. Completed the anterior vitrectomy and did the suturing. So this is at day 3. Quite a lot of haze because of the hyphema. And this is at day 7. PR was inaccurate because of long-standing high IOP, but nevertheless, cosmetic result was good. Coming to the next case, this is a case of chronic PBK for more than 10 years. Limbus does not look too good, but patient was very highly motivated to undergo a surgery. So did a UBM and saw that the IOL was tilted. Ultrasound was okay, mild vitreous echoes. Did a VEP and found that amplitude and latency was also normal. So went ahead with the full thickness penetrating keratoplasty. On cutting the host, to my surprise, there was no IOL. There was a fibrotic posterior capsule with a pre-existing rent adhering to the iris. So I did a gentle synecholysis. Retina surgeon not available, IOP too low, no way to make scleral flaps now. So thought of doing a pinhole pupilloplasty for this patient to achieve maximum visual outcomes. Did the anterior vitrectomy and removed all the fibrotic capsule in the optical axis. And then did the suturing. This is the look at 3 weeks. Pinhole vision and unaided vision is counting finger 2 meters, but with plus 10, it is 6 by 18. Sutures are on. Patient was very happy. This is another case of a long-standing corneal abscess treated for over 2 months outside. There are multifocal infiltrates reaching up to the limbus almost. So here again, I thought of doing a large diameter therapeutic graft. Removed the half of the cornea and kept a hinge to see how the anterior chamber looks. And the lens had quite a lot of exudates over the anterior capsule. Tried to remove this. If not, then ECC would have been done. Looked at the equator because sometimes when we remove the iris and there's a long-standing hypopyon, these exudates might reach up to the pars plana, which requires a lensectomy, vitrectomy. Coming back to my case again, inflammatory membranes over the iris were removed, and now started the positive pressure. The graft was large, patient was young, mannitol was given, but still there was a very high risk of expulsive hemorrhage. So I sutured back the host and now put viscoelastic over the host and placed the graft over the host and sutured at 4 new quadrants. Then slowly release the sutures of the host and without damaging the iris or the lens, pulled out the host. Now the chamber was closed and it was quite easy to suture with no positive pressure. This is the look at day 10. At 2 months, now at 6 months, his graft is failing, so he will be posted for a DSEC or optical triple. Now sometimes there's a large corneal abscess which is almost perforated. Care needs to be taken here because, like in this case, first suture for the Flieringa ring and the lens is out. Now this is a sticky situation, so first I made the graft and then started dissecting the host. Tried to keep the lens at its place for as long as possible to avoid a longer duration of an open sky. Dissected the iris from the host. Thankfully, the anterior chamber did not have much exudates and the iris also looked healthy. Vitrectomy machine was not available on that day. So I did a manual vitrectomy and did the suturing. At the end, I checked for any synechiae or any remaining vitreous tags, completed the vitrectomy, and closed the case. Now, this is a case of a normal optical triple. Rhexis was complete, rigid PMMA IOL in the bag, but due to long-standing pupillary dilatation, the lens is coming in front of the iris and there are iridocapsular adhesions. Now, this will lead to an optical capture and will cause a problem. So I tried to do a synecholysis for this case. Injected Heal-On between the iris and the IOL. Very gently tried to remove the synechia, trying not to damage the lens or the bag here if possible. And thankfully 360 degree I could achieve the release. Pupil was constricting. Iris looked healthy, so did a single 4th row pupilloplasty. Straight needle passed 9-oproline by railroading. And it went well. Heal-On is easy to remove. So this is at day 7. Again, the pupil here is a little dilated. And this is at 6 months. Patient has unaided vision of 6 by 18 with sutures on right now. So to conclude, you need to always be ready with all your armamentarium because you don't know what lies beneath. That's all from my side. Thank you for your patient listening. Over to Nikunj.
Thank you, Dr. Nidhi. That was an amazing presentation as well as collection of surgical videos. And being a cornea person myself, then when we open any therapeutic case especially, it is never just only PK. there is something or the other. And even in optical cases, but if generally I have seen that most of the therapeutic cases, there is a lot of surprises we get when we remove the button. So another, for the benefit of audience and for other people also, that I would like to know, what do you prefer when you plan a triple procedure for IL calculation? What is the method, how you do the IL calculation? Do you take the other eye measurements, or like is there any other way? What is your preferred technique?
Mostly we would take the other eye, because here the cornea will be scarred, or it's not possible, or it's a regraft many a times. Otherwise, we can take the axial length and take a standard keratometry and then do the calculation. So that also has a lot of surprises. Sometimes it fits quite well and vision is quite good, but even after the calculation, I would still try to keep the patient more on the myopic side.
Right. And what is your way of removing sutures? At like, what do you follow? Like at what months, and how do you go for suture removal? Do you do topography based and then selective suture removal, or how do you do it? Like, take care of the astigmatism part as well?
Yeah, for optical cases, first of all, we would like to keep the sutures till 1 year. If there is excessive astigmatism, then topographic guided suture removal can be done. It can start from 3 weeks as well. But I still wait, because I'm still new to this. I wait for at least 3 months, and then according to the topography, I would do in few of them. The other thing is, when you're doing topographic guided, you want them to come back again to you. So people who are living too far, that might be a problem. In therapeutic cases, if there's a large graft with multiple sutures, most of them will get loose. If there are a lot of sutures, you can remove few of them. If vascularization is starting, or sometimes some sutures are repeatedly getting loose at particular areas, it's better to remove them, else they'll attract vascularization and then trigger a graft rejection.